Hello, dear students. Topic today is gastrointestinal tract infections in children. Acute gastroenteritis remains a major cause of morbidity and mortality in children around the world, accounting for 1.34 million deaths annually in children younger than 5 years, or roughly 15% of all child deaths. As the disease severity depends on the degree of fluid loss. Accurately assessing dehydration status remains a main step in preventing mortality. Causative agents. Most infections of the gastrointestinal tract manifest as diarrhea, a clinical syndrome of diverse origin associated with frequent loose or watery stools, often accompanied by emesis, fever, abdominal bloating or pain, and occasional extraintestinal manifestation. Different causative agents. There are viruses, about 70%, such as rotaviruses, noroviruses, enteric adenoviruses, caliciviruses, astroviruses, and different types of enteroviruses. And about 10 to 20%, it is bacteria, Campylobacter, non-typhoid Salmonella, enteropathogenic Escherichia coli, Shigella, different types, and Escherichia, and Shigella toxin producing Escherichia coli, and Salmonella typhi, and different types, and less common protozoa and helminths. Viral gastroenteritis. It is thought that viruses are responsible for up to 90% of all infective diarrhea. The most commonly infections gastrointestinal tract. It is viruses. Viral gastroenteritis is the second most common viral illnesses after upper respiratory tract infections. Rotaviruses are responsible for 500,000 deaths a year. Many different types of viruses are found in the gut, but only some are associated with gastroenteritis. Viruses found in the intestine, and 1 part of all viruses associated with gastroenteritis, such as rotaviruses, adenoviruses 40 and 41 types, caliciviruses, noroviruses, sapoviruses, and other viruses. What else? There are viruses which found in the intestine, not normally associated with gastroenteritis. Polioviruses, Coxsackie A and B, EHA, enteroviruses, hepatitis A and E, adenoviruses, and reoviruses. And C group found in the intestine as opportunistic infection, such as cytomegaloviruses, human simplex viruses, herpes simplex viruses, and varicella zoster viruses, and human immunodeficiency virus. In this picture, you can see particular rotaviruses, particle rotavirus. It is naked double-stranded RNA viruses, 90 nanometer in diameter, also found in other mammals and birds, causing diarrhea, account for 50 to 80% of all cases of viral gastroenteritis, usually endemic but responsible for occasional outbreaks, causes disease in all age groups but most severe symptoms in neonates and young children. Up to 30 mortality rate in malnourished children, responsible for up to 500,000 deaths per year. 90% of the population have antibody against rotavirus by the age of 3, more frequent during the winter. Fecal-oral spread, respiratory droplets. This fact is discussed now, and 24-48 hour incubation period followed by an abrupt onset of vomiting and diarrhea. A low-degree fever may be present, diagnosed by electronic microscopy or PCR diagnosis or ELISA and other assays. Live attenuated vaccine now available for use in children. In this picture, adenovirus particle, naked DNA viruses, 75 nanometer in diameter, fastidious enteric adenovirus type 4, 40 and 41 are associated with gastroenteritis. Associated with causes of endemic gastroenteritis, usually in young children and neonates, can cause occasional outbreaks. Possibly the second most common viral cause of gastroenteritis, similar disease to rotaviruses. Most people have antibodies against enteric and adenoviruses by the age of 3. Diagnosed by electron microscopy and PCR diagnosis and ELISA and other assays. Astroviruses particle. Small RNA viruses, named because of star-shaped surface morphology, 28 nanometer in diameter, associated with cases of endemic gastroenteritis, usually in young children and neonates, responsible for up to 10% of cases of gastroenteritis, similar disease to rota and adenoviruses. Most people have antibody by the age of 3, diagnosed by electronic microscopy only because very difficult of small size, small virus. Noroviruses. Small RNA viruses with rigid surface, 35 nanometer in diameter, are now classified as caliciviruses, always associated with epidemic outbreaks of gastroenteritis. Adults more commonly affected than children, associated with consumption of shellfish and other contaminated foods, aerosol spread possible, as well as fecal-oral spread. Also named winter vomiting disease, with vomiting being the prominent symptom, diarrhea usually mild. Antibodies is quite later in life. In the USA, only 50% of adults are seropositive by the age of 50. Diagnosis is made by electron microscopy and by real-time PCR. Sapovirus particles in this picture, small RNA virus, characteristic surface morphology, consisting of hollows, particles 35 nanometer in diameter, associated mainly with epidemic outbreaks of gastroenteritis, also occasionally responsible for endemic cases. Like noroviruses, vomiting is the prominent feature of the disease. Majority of children have antibodies against sapoviruses by the age of 3. Diagnosed by electron microscopy only, often difficult to diagnose because of small size. As other possible diarrheal viruses, coronaviruses, and small round viruses. Bacterial causes. It is a little part of all gastroenteritis in children. In developed countries, bacterial pathogens account for a small portions, perhaps 2 to 10% of all cases of pediatric gastroenteritis. The most important pathogens are Campylobacter, Salmonella, Shigella, and intrahemorrhagic Escherichia coli species. Relative to viral gastroenteritis, bacterial disease is more likely to be associated with high fevers, shocking chills, bloody bowel movements such as dysentery, abdominal cramping, and fecal leukocytes. In developing countries, enterotoxigenic Escherichia coli remains the most important bacterial cause of acute gastroenteritis in children, followed by Campylobacter, Salmonella, and Shigella, while also causing the majority of travelers' diarrhea in all age groups. Clostridium difficile has emerged as an important cause of antibiotic-associated diarrhea in children. Any antibiotic can trigger infection with Clostridium difficile. Also, penicillin, cephalosporins, and clindamycin, and they are the most likely causes. In this picture, I show any characteristic of bacterial causes such as Staphylococcus aureus, Salmonella, Escherichia coli, Shigella, Campylobacter, and Vibrio cholera. And this presented main characteristic of this pathogenic Salmonella, Campylobacter, Vibrio, Shigella, enterotoxigenic Escherichia coli, Clostridium perfringens, and other incubation period presented and duration of disease and main signs of this disease. Salmonellosis. Salmonellosis, an infectious disease caused by bacteria Salmonella with a fecal-oral transmission mechanism, occur with a predominant lesion of the gastrointestinal tract. According to the ethiopathogenic classification, salmonellosis refers to the invasive type of diarrhea, but can also occur according to the mixed invasive to secretory type. The incidence of salmonellosis in the PEM region is 74% higher than in Russia. Salmonella enteritidis predominates in the structure of Salmonella in the PEM. Annually registered in the PEM region are 1,500 to 2,000 with half cases of salmonellosis, most among children from 1 year to 2 years. Epidemiology. The source of infection is humans and animals, patients and bacteria carriers. Fecal-oral mechanism, transmission ways, foods such as eggs, chicken meat, insufficiency had treated. Contact household and water less often. Classification. There are localized forms of salmonellosis and generalized forms. Localized forms are gastritic variant in cases when only vomiting in clinical picture, and gastroenteritic variant when we have damage stomach and enteric damage, and gastroenterocolitic variant. And generalized forms are typhus-like forms and septic form. There is carrier state, such as acute carriers, chronic carriers, and transitory carriers, depends on time of carriers. How long carriers? Symptoms. The incubation period is up to 7 days. Acute angst, prolonged fever, fever about 37, 38, and 39 degrees Celsius. Signs of intoxication and local manifestation from the digestive tract. Local change syndrome. Gastrointestinal tract lesion is a leading symptom. Soreness and rumbling in the right iliac region. Fishes a dark green color, such as swamp moot and frog caviar. dehydration syndrome, and hepatosplenomegaly syndrome. Shigellosis, dysentery. Shigellosis is a type of food poisoning caused by infection with the Shigella species. It is a major public health problem in developing countries where sanitation is poor. Shigellosis is spread by means of fecal-oral transmission. Shigellosis follows a self-limited course ranging from 3 days to 1 week. It rarely lasts as long as a month. Epidemiology. Shigella species such as Shigella dysentery, Shigella flexneri, Shigella zonai, and Shigella bodi are aerobic, non-motil glucose fermenting, gram-negative fruits that are highly contagious, causing diarrhea after injections of the few as 180 organisms. The organism is spread by fecal-oral contact via infected food or water during travel on or in long-term care facilities, daycare centers, or nursing homes. Symptoms of shigellosis. The main symptoms are acute bloody diarrhea, abdominal cramping, tenesmus, fever, occasional vomiting, dehydration, toxicosis, and distal colitis syndrome. It is very important symptom during shigellosis. Pathophysiology. There are two primary mechanisms responsible for acute gastroenteritis are one, the first, damage to the bilious brush border of the intestine, causing malabsorption of intestinal contents and leading to anosmotic diarrhea. And second way, the release of toxins that bind to specific enterocyte receptors and cause the release of chloride ions into the intestinal lumen, leading to secretory diarrhea. In this picture presented the pathogenesis of rotavirus infections. The first part of leading of this disease, rotavirus particle in enterocytes, cell lysis and enterocyte lysis and malabsorption in intestine and different cell interactions and damage of ions passage. And this process leading of secretory and osmotic diarrhea. In this scheme, you can just see how what pathogenic process lead to diarrhea, such as osmotic diarrhea. Increase in intestinal osmotic pressure leads to transfer of fluid of the intestinal tract, and this leads to diarrhea. And exudative diarrhea. What process? Intestinal mucosal disorders such as inflammation. These changes leads to increase in intestinal contents due to exudate, and this leads to diarrhea. Secretory diarrhea, enhancement of intestinal secretion by enterotoxins, leads to increase in intestinal contents, and this leads to diarrhea. In this table, you can just see a different characteristic of different type invasive secretory and osmotic diarrhea and causative agent which lead to different types of diarrhea. It is very important to remember this is degree of dehydration. Degree of dehydration is main syndrome which we must see in patients and administered different type of therapy, different volume of therapy. And there are three types of dehydration: no or minimal dehydration, and mild to moderate dehydration, and severe dehydration. Minimal dehydration, it is mental status is alert, thirst, drinks normally, heart rate and quality of pulses, breathing, eyes, it is normal, and tears present, mouth and tongue moist, skin foot fault instant recoil, capillary refill normal, extremities warm, and urine output normal. But in the mild to moderate dehydration, we have restless, irritability, mental status, thirst, drinks eagerly, heart rate normal to increased, quality of pulse normal to decreased, and breathing normal or fast, eyes slightly sunken, and tears decreased, mouth and tongue dry, skin fold recoil less than 2 seconds, capillary refill prolonged, extremities cool, and urine output decreased. And very important to know about symptoms of severe dehydration. In severe dehydration, there are mental status, lethargic consequences, thirst, drink poorly, heart rate, tachycardia, increased heart rate, and quality of pulses weak or not palpable, breathing deep, eyes deeply sunken, tears absent, mouth and tongue parched, skin foot fold recoil more than 2 seconds, capillary refills prolonged or minimal, extremities cold, mottled, cyanotic maybe, and urine output minimal. What else? In this picture, all symptoms commonly, all symptoms severe dehydration, some dehydration, and no dehydration. You must remember these symptoms. And according to dehydration, we should choose any therapy management, any management of therapy our patients, such as if we have no dehydration, we get for patient replace ongoing losses with oral rehydration solutions. Only oral rehydration when we haven't any dehydration status, and age-appropriate diet. If we have mild dehydration, 3 to 5% of body weight loss, we must administer oral rehydration 50 milliliter per kilogram over 4 hours, the first 4 hours, and replace ongoing losses with oral rehydration and appropriate diet after rehydration. If we have moderate dehydration, 6 to 9 body weight loss, body weight loss, we should administer oral rehydration 100 milliliter per kilogram over 4 hours, and replace ongoing loss with oral rehydration and age-appropriate diet after rehydration. If we have severe dehydration and body weight loss more than 10%, we should intravenous ringalactate or normal saline solutions, different 20 to 40 milliliter per kilogram for 1 hour, the first 1 hour. Reassess and repeat as needed after 1 hour treatment. Begin oral rehydration when is stable. Replace ongoing loss with oral rehydration and appropriate diet after rehydration. Laboratory studies. There are vast majority of children presenting with acute gastroenteritis don't require serum or urine tests as they are unlikely to be helpful in determining the degree of dehydration. Any child being treated with intravenous fluids for severe dehydration, however, should have baseline electrolytes, bicarbonate, and urea creatinine values tested. Fecal leukocytes and stool culture may be helpful in children presenting with dysentery. Children older than 12 months with a recent history of antibiotic use should have stool tested for Clostridium difficile toxins. Those with a history of prolonged watery diarrhea more than 14 days or travel to an endemic area should have stool sent for ova and parasite tests. Any child with evidence of systemic infection should have a complete workup, including complete blood count and blood cultures. If indicated, urine cultures, chest radiography, and/or lumbar puncture should be performed. Bacteriological examination of fishes is the gold standard for the diagnosis of bacterial gastroenteritis. We use nutrient media endo plus criflavin. For etiological diagnosis of viral diarrhea, mainly real-time PCR and ELISA are used. Their methods are more specific, sensitive, and quick. In this picture, I want to show for you how we see any results of laboratory method such as real-time PCR. PCR includes seven different causative agents of children gastroenteritis, such as Shigella and Escherichia coli, intra-invasive strains, Salmonella, different strains, Campylobacter, and viruses. There are four viruses: adenovirus, rotavirus, astrovirus, and norovirus. In these results, we haven't any causative agent, or not any causative agent of acute gastroenteritis. Medical care, pre-hospital care. Children with acute gastroenteritis rarely require intravenous access. In those presenting with circulatory collapse due to severe dehydration or sepsis, intravenous access should be obtained and followed by an immediate 20 ml per kilogram bolus of normal saline. Emergency department care. Initial care in the emergency department should focus on correction of dehydration. The type and amount of fluid given should reflect the degree of dehydration in the child. Minimal dehydration. No immediate treatment is required. If the child is breastfed, the mother should encourage it to breastfeed more frequently than usual and for longer at each feed. If the child is not exclusively breastfed, then oral maintains fluids, including clean water, soup, rice water, yogurt drink, or other fluids. Should be given at a rate of approximately 500 milliliters per day for children younger than 2 years, 1000 milliliters per day for children aged 2 to 10 years, and 2000 milliliters per day for children older than 10 years. In addition, ongoing fluid losses should be replaced with 10 milliliter per kilogram body weight of additional oral rehydration for each loose stool and 2 milliliter per kilogram body weight of additional oral rehydration for each episode of emesis vomiting, both for breastfed and non-breastfed children. Mealtime dehydration. Children should be given 50 to 100 milliliter per kilogram of oral rehydration over a 2 to 4 hour period to replace their estimated fluid deficit with additional oral rehydration given to replace ongoing losses. 10 milliliter per kilogram body weight for each stool and 2 milliliter per kilogram body weight for each episode of emesis. After the initial rehydration phase, patients may be transited to maintenance fluids as described above. Oral rehydration should be given slowly by the patient using a teaspoon, syringe, or medicine dropper at the rate of 5 milliliter every 1 to 2 minutes, very slowly. If tolerated by the patient, the rate of oral rehydration delivery can be increased slowly over time. For patients who don't tolerate oral rehydration by mouth, nasogastric feeding is a safe and effective alternative. Patients should be reassessed frequently by their clinical to ensure adequacy of oral intake and resolution of the various signs and symptoms of dehydration. Severe dehydration. Severe dehydration constitutes a medical emergency requiring immediate resuscitation with intravenous fluids. Intravenous access should be obtained and the patients should be administered a bolus of 20 to 30 milliliter per kilogram lactate ringer or normal saline solution over 60 minutes. If pulse, perfusion, and or mental status don't improve, a second bolus should be administered. After this, the patient should be given an infusion of 70 milliliter per kilogram lactate ringer or normal saline over 5 hours. Or 2 with 5 hours. Once resuscitation is complete and mental status returns to normal, rehydration should continue with oral rehydration, with oral solutions. There are different types of oral solution. Reduced osmolarity oral solutions, osmolarity less than 250 millimole per liter, is associated with fever treatment failures, lower stool output, and less frequent vomiting compared with standard osmolarity oral rehydration solutions for patients with non-cholera gastroenteritis. Clinicians can use homemade solutions. Feeding and nutrition. In general, children with gastroenteritis should be returned to a normal diet as rapidly as possible. Early feeding reduces illness duration and improves nutritional outcomes. Breastfeed infants should be continued to breastfeeding throughout the rehydration and maintenance phase of acute gastroenteritis. Formula-fed infants should restart feeding at full strength as soon as the rehydration phase is complete. Weaned children should restart their normal fluids and solids as soon as their rehydration phase is complete. Fatty foods and foods high in simple sugar should be avoided. The goals of pharmacotherapy are to reduce morbidity, prevent complications, and provide prophylaxis. Antidiarrheal and antimotility agents such as loperamide, and contraindicated in the treatment of acute gastroenteritis in children because of their lack of benefit and increased risk of adverse effects, side effects, including ileus, drowsiness, and nausea. The mainstay of therapy includes prevention with the rotavirus vaccine and treatment with antimicrobials and antiemetics. There are different antibiotics against bacterial causes of gastroenteritis in children. The first line of therapy is nitrofuroxazide, and there are different form capsules and suspensions, and there are what antibiotics? Cotrimoxazole and chloramphenicol. Uh, and we have any drugs such as Saccharomyces boulardii is a non-pathogenic yeast reportedly able to protect the invasive against Clostridium difficile and halitotoxin, clinically effective in preventing antibiotic-induced diarrhea, diarrhea associated with tube feeding in critically ill patients, and recurrence of Clostridium difficile infections. There are prebiotics and probiotics. Probiotics, this is a living microorganism which, when administered in adequate amounts, have a positive effect on the health of the host. And prebiotics, non-absorbable substances that have a positive physiological effect on the host, selectively stimulating the necessary growth of activity of intestinal microorganisms. All these drugs is biological additives. Enterosorption therapy, it has selective sorption properties, absorb bacteria and viruses located in the lumen of gastrointestinal tract. In the lumen of the digestive tract, there are brung beans, there removes endogenous and exogenous toxic substances of various nature from the body, including pathogenic bacteria and bacterial toxins, antigens, food allergens, and drugs. In February 2006, the USA Food and Drug Administration approved the Rototec vaccine for the prevention of rotavirus gastroenteritis. The vaccine has been endorsed by the American Academy of Pediatrics, and in April 2008, the FDA approved Rotarix, another oral vaccine for the preventing of rotavirus gastroenteritis. Clinical trials reported that the vaccine prevented 74 to 78% of all rotavirus gastroenteritis cases. Nearly all severe rotavirus gastroenteritis cases and nearly all hospitalization due to rotavirus among children. I want to present for you a clinical case. An 8-year-old boy was admitted to the emergency room on February 10, 2018 because he had suffered from severe diarrhea, more than 6 stools per day, vomiting 3 episodes per day, and high fever, more than 39 degrees Celsius over the previous 2 days. He didn't have any unusual travel, dietary, or animal contacts, and didn't receive any doses of rotavirus vaccine. In the emergency room, the child was drowsy, body temperature was 38.7 degrees Celsius, heart rate 170 beats per minute, respiratory rate 50 beats per minute, and blood pressure 85 on 45 millimeter hydrogram. Severe dehydration was evident. The weight was 2.5 kilogram lower than that evaluated several days before disease onset, revealing a 10% loss. The oral mucus was very dry, eyes sunken, and skin liftable in persistent folds. Moreover, no urine was found in the bladder after catheterization. Laboratory tests revealed low serum concentration of both potassium and sodium, confirming hypoelectrolytic gastroenteritis. Glycemia was lower than the normal. Kidney function tests showed a relevant pre-renal failure, with creatinine at 2.48 milligram per deciliter and urea at 133 milligram per deciliter. Severe acute gastroenteritis was diagnosed and the child was hospitalized. After hospitalization, fecal samples for bacteria and virus identification were collected. Cultures for all the bacterial pathogens usually associated with acute severe gastroenteritis were negative, while an enzyme immunoassay for the detection of RNA rotaviruses was positive. A sample of fishes was used for reverse transcription polymerase chain reaction and nucleotide sequencing of the infecting rotavirus. Intravenous fluids were immediately administered according to the World Health Organization recommendation, and the response was rapid. Diarrhea progressively reduced, vomiting disappeared, and oral feeding was resumed the day after admission. Blood pressure, heart rate, and respiratory rate returned to normal values within 24 hours, as it was for diuresis. Pre-renal failure disappeared after 48 hours. Weight returned to initial values within 1 week. On this case, we complete our lecture, and goodbye.